Welcome to Between Two Ovaries,
our women's health podcast,
where we'll be telling you the facts and debunking the myths.
We'll be keeping it chatty and casual, and you can follow us on Instagram at Between Two Ovaries. Hi, welcome back to our podcast. So we hope you enjoyed our last episode, which was on how to get pregnant. Today we're going to be talking about endometriosis.
So we thought it was really important to do an episode of endometriosis. This is kind of our bread and butter and what we see all the time as part of our work. And I know that you guys are kind of doing research which covers endometriosis as well. So we're kind of immersed in the world of endometriosis. But I do think that there is a lot more publicity now around it. I think a lot more people know what it is. I've heard different people talking about it on their podcasts. Abby Clancy and Peter Crouch had like an episode just on endometriosis, which I think is great to get the publicity out there so that people kind of understand what it is and how they may be affected, how others around them may be affected, and what we can do and what others can do to try and help people in the future.
Yeah, definitely. I think it's one of those things where like knowledge is power, and it's really good that we know more about endometriosis now than we used to, and it's more talked about. Women have heard of it. GPs are more aware. You know, it's definitely more a more hot topic than it used to be. Yeah. But unfortunately, we're still really lagging behind with like the funding for the research side of things. Not much funding goes to women's health research, even though women make up half of the population, and like of all of those women, many will have endometriosis, about 10%. So this is another way of us kind of like spreading the awareness about the importance of endometriosis and understanding what it is, and then also highlighting what we don't know and what we need to learn more about in the future as well.
Yeah, I think that is totally what we need to do.
Yeah.
So endometriosis, what is it, and what do people know about it? Look, I feel like you've been more immersed when you've come to work with us.
Yeah, no, definitely. Do you want to go for it? What do you think it is?
We're testing your knowledge now. You've been with us for a year. Come on, tell us what it is.
So endometriosis is where the cells in the lining of the womb grow outside of the lining of the womb. Yeah. And it can cause some symptoms like chronic pelvic pain, but also sometimes it doesn't always have to have symptoms.
Yeah.
Mm-hmm. Yeah, absolutely. So it is. So yeah, we know we've got the womb, and inside the womb we've got the endometrium, and the endometrium is the bit that's shed every month when you have a period, if you have periods. And then in endometriosis, the cells from the lining of the womb find their way into the pelvis, most commonly the pelvis, but then can also go anywhere else in the body in certain circumstances as well.
Yeah, we're probably not going to talk much about like very rare cases of endometriosis, but some people have been found to have it kind of in their lung cavity and various different things. So these are obviously very specific cases and need treating and seeing in very specialist centres. We're probably not going to talk about that. Yeah. I think on the whole, people that are affected with endometriosis have symptoms to do with their pelvic, so to do with their pelvis, their abdomen, and they would have symptoms relating to that rather than anywhere else.
And it affects around 10% of women of reproductive age. That's kind of the most widely reported statistic. Yeah. But it is actually quite hard to know exactly how many people have it, which I think we'll touch a bit on, because getting a diagnosis can take a bit of time. And also there's a lot that we don't yet know also about endometriosis. So we will touch a bit more on that. I think let's go over the symptoms, because they're so wide and far-reaching. Yeah. Common symptoms are heavy periods, but you might have endometriosis and not have heavy periods. And then pain is a big one. Yeah. So as you said, pain can affect the pelvis, but it can also be other parts of your body as well. Lots of people have pain that kind of goes down their legs. It can be higher up in their tummy. It can be general body aches and fatigue.
A lot of people say fatigue and bloating are the biggest symptoms, which at first I don't think they were even linked to endometriosis. Endometriosis was a lot more like pelvic pain, and that's it. So it's an estrogen-dependent chronic inflammatory disease. So we have like battered home about these hormones on all of the episodes so far. So estrogen is what dominates the first part of your cycle. Progesterone is what dominates the second part of your cycle. This is the menstrual cycle. So if you have a pretty regular 28-day cycle, 14 days of it will be dominated by estrogen. So it's an estrogen-dependent chronic inflammatory disease. So these bits of endometrium that are outside of your pelvis, so outside of where your endometrium is, inside your pelvis, sorry.
So we call them ectopic endometrium, don't we? Which is quite a nice way of putting it.
Yeah.
So ectopic being outside of where they should be, so ectopic endometrium.
Yeah, so these kind of bleed and cause pain, or that's why we think people have pain, or sometimes people can be kind of sensitized to them and that's why they have pain. They also cause pain because they can cause lots of adhesions, so things stick to each other. So we can find in the most severe cases would be a frozen pelvis, so everything is stuck to each other. So the womb is stuck to the tubes, is stuck to the ovaries, and it's all really stuck down and into the pelvis, and then you call it kind of an obliterated pelvis basically. So like you can't get in and find where the normal kind of anatomy is.
And a lot of the time you get those adhesions or that scar tissue because, as you said, the endometrium will respond to estrogen and it will kind of grow and proliferate, and then when that estrogen drops and you have more progesterone, it can then try and shed, and it can shed. Obviously, if it's in your pelvis, it's not in your womb, it doesn't go anywhere, it stays there. And then your body can respond by mounting like an immune response to try and attack it. And then that can form scar tissue. And that can make things painful because if your organs are stuck to each other, then as you are digesting or going to the toilet, there will be pain because there's less movement and things are kind of stuck down.
Oh yeah, so when we were talking about symptoms very briefly at the beginning, like we didn't talk about people have really bad pain when they're going for a poo, really bad pain when they're having intercourse, some people have pain when they're going for a wee. Like you can have pain related to anything there basically.
There's lots of symptoms that overlap with other conditions as well.
Yeah.
So I can see how it'd be hard to define what you think. Do I have endometriosis? Do I have IBS?
Yeah. There's a lot of crossover with lots of different things.
And it's also not just it's not just pain when you're on your period, I think, which is really important to know. Like a lot of people have pain in between their periods or unrelated, and that can be caused by endometriosis, but that's really hard because it can also be caused by other things as well.
Yeah.
So how do you go about diagnosing this?
Yeah, so this is difficult because we don't know why people have endometriosis. So the research that has been done, although we've kind of highlighted at the beginning that money for women's health research is kind of tiny in comparison for other forms of research.
So it's only 2.9% of the UK's publicly available funding goes to women's health research.
Wow.
Which is crazy, isn't it?
Doesn't it know women's health is one of the most under-researched areas as well?
Yeah.
They need to give us more money.
It's crazy. And like, you know, if endometriosis affected men, you just know for a fact that like we would have found the cause. we would have found the truth.
Time off work.
Yeah, I think women's health it kind of all gets lumped together.
Yeah.
And that's pregnancy and non-pregnancy and endometriosis, and then we only get a really small amount of funding, so it's really hard to actually progress. It takes a lot of time.
Once you split it out into different pots of different areas of research, it's not less of a lot.
But anyway,
it's difficult because
I digress.
everybody has their priorities, don't they? And endometriosis for some people is not a priority, but if you have endometriosis, or if you're a researcher for endometriosis, like it is a priority, and you just kind of feel like you're bashing your head against a wall slightly.
But like if you can release the burden of endometriosis on society as a whole, like everything would get better. You know, women will not be able to go to school, not be able to go to work sometimes.
So productivity
would be everyday activities.
No?
Yeah. So it affects not just the women who have it, it affects society as a whole.
The
as well.
economy. If people can't go to work, then so it does affect everyone.
So it really does.
Sorry, carry on.
So the problem is we don't know what causes endometriosis. So there's lots of theories by which we kind of think it might be caused. They kind of most widely held theory is that you have retrograde menstruation. So you have a period and it goes through your fallopian tubes out into your pelvis, so out into your tummy.
And I think a lot of people don't know that the fallopian tubes are not attached to the ovaries, they're not kind of stuck on the ovaries. So they're nearby, and then when you release an egg, the tubes will kind of like waft the egg in.
We've laughed about
wafted. Was
so
it in the How to Get Pregnant?
It was, yeah. So please listen to that episode if you haven't already. But yeah, so the tubes are kind of, open into the pelvis. So when you have a period, the blood will mostly come out of the womb into the vagina, but it can also go back through the tubes and then be in your pelvis. And that's retrograde menstruation.
But a lot of women have this and don't have endometriosis.
Yeah.
So it's
not
be
a proven theory.
No, it must be a subset of people that have this retrograde menstruation, so period blood coming out of their tubes into their pelvis, but it's sticking, it's causing these lesions, something happens, like why do some people get it and not others?
Yeah.
And we genuinely don't know why it's in other places that are outside of the abdomen.
Which is why we need more money for more research.
There's loads of different theories, and I think we definitely aren't going to be able to narrow down that, and especially in a podcast episode. But I think it's good to know that we are not on board with exactly what's happening. So that's why it's very difficult to be able to relate an exact symptom to the cause. And different people have just so many different symptoms, and it can affect various bits of their life quite detrimentally. But then you have some people that will come for an operation to stop them being fertile, so something called a laparoscopic sterilisation. So we go in with a port and clip the tubes so that they can't have any more babies. Obviously that's what they want.
Yeah, this is
no more
unrelated
children.
to endometriosis. This is just sort of like, a woman who is absolutely fine, doesn't have any problems
decided
with her
that they
periods,
finished their family, wants to have
sterilisation.
contraception, come in for a laparoscopic sterilisation, and we can't do the procedure because they've got a frozen pelvis and we actually can't get in to be able to find their tubes. So they've got such severe endometriosis, but they've managed to have children. They're not like, they're like, oh yeah, symptoms. My periods are a bit heavy, but they're not like nothing that they're kind of too worried about. So the symptoms and how they affect different people are really very different,
and
which
someone can have like minimal actual endometriosis but still have absolutely horrendous pain, and also could have horrendous pain, come to see if they've got endometriosis and not find anything.
Yeah, because it's only one cause of chronic pelvic pain, and I think that's really important. There are different causes of chronic pelvic pain. Some of them are gynecological causes like endometriosis, adenomyosis, but equally there are lots of other things in your pelvis that can cause pain. And I think that's one reason it takes so long to get a diagnosis, which isn't right, but it is hard sometimes to know exactly what is causing the symptoms. I think it's also, although we don't know the exact cause, there is kind of a general acceptance that there are different types of endometriosis, which I find really useful, and it also feeds into diagnosis as well. So generally speaking, there are kind of three main types of endometriosis. So we've got one called superficial peritoneal, which essentially is just where you have deposits of endometrium outside of your womb, and it kind of coats your pelvis. So it might just be on like the walls of your pelvis.
You usually have like different spots. So you'll have a spot on a ligament, a spot on like behind where your womb is, or a spot on the front of where your womb is, like just like different little spots that you can see when you're doing the diagnostic.
And the only way to diagnose that is with a laparoscopy. So it's a surgical operation, a diagnostic operation, where you actually have to physically go and have a look inside and see those deposits. And then you've got an ovarian endometriosis, which only affects, or if you have this, it affects your ovaries. So women who have this will have essentially cysts on their ovaries, but they're full of endometriosis and kind of menstrual blood.
Okay.
And so you can actually see some of these on an ultrasound scan. Yeah. So it can be diagnosed separately to a surgical procedure.
Conservatively then, yeah.
And they're quite often called chocolate cysts.
Chocolate cysts.
I've read that actually, and I've always been like, why have we got chocolate in there? Like, what's going on?
Because it looks like liquid chocolate.
Genuinely.
You drain a cyst.
Like melted chocolate.
Yeah, it comes out like a dark brown liquid.
Interesting.
But like about old
like
blood.
a thick can of liquid.
That melted chocolate kind of viscosity.
It doesn't sound very appetizing.
No, I'm not sure.
Could be described in a worse way, I guess.
Yeah.
Chocolate cyst is quite nice. But then, you've got a frozen pelvis, or another word for that, I guess, would be like deep infiltrating endometriosis, where the endometriosis is affecting your bowel or your bladder, and it's invading kind of other organs.
Does this relate to the stages of endometriosis?
So no, that's like a separate thing, and it's really complicated because there are different staging systems for endometriosis. Yeah. So you could say, stage 1 to 2 in one form would be equivalent to superficial endometriosis. But I personally find staging not very helpful because it suggests that it is a progressive disease, that like if you start with stage 1 you will get to stage 4, which isn't true for endometriosis.
We just don't know. So I think a lot of things, and I think that they did touch on that on Abby Clancy's podcast about the catching it early so it doesn't progress, but the literature is not there for that.
We just don't know, I guess.
And we have done various studies looking into this, and others have done loads of studies looking into this, and it's quite difficult, obviously, because you're wanting to do a laparoscopy and then do another laparoscopy in, say, 5 years' time, just to see what's happened, which we can't do, because you can't do a laparoscopy just to see what's happened. They're not without risk. And also, a lot of people will have had treatment in between. So we genuinely don't know what happens. I think maybe some people have a progressive form, but others will have superficial endometriosis and have it treated properly, and then will never have endometriosis again.
Oh, wow.
So I think it's really difficult to kind of say, oh yeah, it's progressive. If you started with 1, then you're going to end up with 4. So have a hysterectomy early. Like I think
it's not. There's not enough evidence there yet to say it definitely does. But also you might have an ovarian endometrioma in your life that gets seen on an ultrasound scan, and then you may not get one again. It may go away on its own, or you may have some treatment and it goes away, but it doesn't always mean that you will then be someone that goes on to get deep infiltrating endometriosis. So it's important to clarify that.
I think we should say as well that when you said go and have a little look to see if you've got endometriosis, that this is a keyhole procedure that will take a little camera through a hole. It's not like full open abdomen.
No, it's a generally very safe procedure. So, it's something that we do as a day case often. So you'll come in, you'll go to sleep, there'll be a camera that's put through your belly button, you blow up your tummy with gas, then you put some other ports in and have a look. We say it's a diagnostic laparoscopy, so it's to see if you can see any endometriosis or see any cause.
See any other cause.
You might not see any, so it may just be that you have a look.
And sometimes we see other things, like you might find that actually someone's had a chlamydia in the past or another infection in the past, and they've got adhesions, so everything's stuck to each other, not because of endometriosis, but because of a previous infection, and you can see that quite clearly sometimes with no endometriosis there. Sometimes people have had lots of surgeries before and they've got adhesions because of that, so everything's stuck to each other. Some people, even after a simple appendix removal, so they've had an appendectomy because of appendicitis, they've had an infection after that, and they can have like a terrible looking pelvis just because of that. So it's not just endometriosis that causes pelvic pain, and we don't just find endometriosis on diagnostic laparoscopies. We do pick up lots of different things.
And there is always a chance that we won't see anything, but that doesn't mean you don't have pain or we don't believe that you have pain. It is just one step of the process to finding out what is causing your pain. The other thing as well is with MRI scans, you can do a pelvic MRI, and that can pick up certain types of endometriosis. So you would be able to see an endometrioma, so the ovarian type, and if it was involving your bowel, you might see that on an MRI scan as well. Not perfectly, not everyone, but it can be a helpful addition.
MRIs sometimes are great when you have a diagnosis of endometriosis. So if you go in and do a diagnostic laparoscopy and you're found to have quite severe endometriosis, they will do an MRI to see how much of the bowel is involved, how much of the bladder is pulled in, to see if you're going to have surgery, who needs to be there? So which surgeons do we need on hand that can help with an operation if you have various different pieces involved? So MRI is quite good in just as we use it for cancer, really, like a staging operation, a staging procedure to kind of decide what we're going to do. Flipping back just quickly to the diagnostic laparoscopy, as we said, there is massive waiting lists, and it's not a great service from that respect presently. It's quite difficult because we have so many people coming through that are possible cancer patients that the diagnostic laparoscopies unfortunately get pushed, which is awful because people are at home and they're suffering and we're like, oh, we're really sorry, like we've just not got room. But a diagnostic laparoscopy is not suitable for everybody. Yes, it's a low risk procedure, but it's not a no risk procedure. Nothing that we do is a no risk procedure. And this still involves a general anaesthetic, so an anaesthetic at the end of the day, but it also involves us putting a sharp needle through your tummy button, which again, we do this all the time, so it's a low risk procedure, but inevitably sometimes it will go through bowel, it will go through major blood vessels, and people end up with complications. And I think that people need to be counselled appropriately because it is a diagnostic procedure. We need to kind of risk up the benefits and weigh up the benefits and the risks. And for certain people, the risk would be too high to do that. So if somebody has, they're carrying quite a lot of extra weight, or if somebody's had quite a lot of surgery before. So some people sometimes have lots of surgeries when they're babies or when they're in their teens, and they've got what they would call like a midline laparotomy, so a cut like all the way down their tummy. These people probably aren't suitable to have a diagnostic laparoscopy procedure, and so we need to think about kind of treatments and what we can do if we're just doing it as a diagnostic procedure, like because we need to be safe at the end of the day.
Yeah.
So if during a diagnostic laparoscopy the doctor did find endometriosis, what would happen?
Okay, so it depends. It depends what stage and type of endometriosis, and it also depends what they want. So if you're coming to me and you're 28 and you've not been able to get pregnant, and we've done a scan and it looks like you've got endometriomas, so in your ovaries you've got these cysts, these chocolate cysts in your ovaries, we would drain those to try and decrease the inflammation or decrease the symptoms that they're causing, but we wouldn't usually try and excise them and get rid of as much as possible, because inevitably when we excise these we get rid of ovarian tissue. You want your ovaries to be working if you want to get pregnant. So it depends how aggressive we are, would depend on what your outcome wants to be. And so it's quite specific to the person. So if you're having problems with pain, but you've completed your family, that's quite different to somebody who all they want to do is get pregnant. And we need to be able to get rid of the endometriomas so that we can access the ovaries, or we need to kind of free up the adhesions so that the ovaries in the right place so that we can kind of do an IVF cycle. It's really dependent on who and what we see, I think.
Depends on the person, their symptoms, and then also, like you say, a lot of the time fertility wishes come into it, which is important because, some people don't want children, and that's absolutely fine, but some people will, and then that will impact which treatments would be suitable for them, like you say, about operating on the ovary. You might not want to do that so much if someone does want to try and conceive, because it will reduce their chances.
So endometriosis does have an effect on fertility?
In some people, yes, but not all people. And again, this is one of those things that's just really not that well understood. So if you have endometriosis, it doesn't mean that you won't get pregnant. A lot of people have endometriosis and have no problems getting pregnant and having children, but it is associated. So we do know that in women with endometriosis versus those without, women with endometriosis have a higher rate of infertility or difficulty getting pregnant. But it's not everyone.
It's definitely not everybody. And there's loads of kind of consultation and discussion about why do people with endometriosis have a decreased chance of getting pregnant. And there's loads of theories behind it. It's not just because of the endometriosis, because as we said, people are going to have loads of different types of endometriosis and lots of different things going on. Is it the endometriosis? Is it because they can't have intercourse because it's too painful? Is it because they've got heavy periods so they're not having intercourse? There's actually quite a lot of different reasons.
And inflammation as well comes into it. If you've got endometriosis on your tubes or your ovaries, that can produce inflammation that can affect the lining of your womb.
Have you got endometriosis in your tubes and your tubes are blocked? Have your tubes been kind of twisted so that actually you've got kind of a tubal factor in fertility because the fallopian tubes aren't doing their job, like you're not able to get that
swollen and twisted and stuck and they
egg to where it needs to be. So there's lots of theories, reasons why people with endometriosis don't get pregnant. But you're quite right. The proportion of people in a fertility clinic with endometriosis is much higher than in the general background population, but I don't think it's as simple as saying you're infertile because you have endometriosis. Lots and lots of people get pregnant without issues with endometriosis.
I guess that brings us kind of nicely onto the treatments, because there is a little bit of an overlap with diagnostic procedures and treatments, and it is again very kind of person specific, but generally speaking, a lot of people who have symptoms or signs of endometriosis will first of all go to their GP, and their GP can't just do a diagnostic laparoscopy straight away, and so actually the guidelines for managing symptoms of endometriosis, regardless of whether you know it is caused by endometriosis or not, is to try some medical treatments. And our medical treatments that we have kind of broadly, we have pain relief, non-hormonal, so, you know, paracetamol, ibuprofen. We also have some medication that can help reduce the heaviness of periods that's not hormonal. And then we have hormones, which we have talked a little bit about in a previous episode on the Marina coil, which you should listen to if you've not listened to already, because it's excellent. But yeah, so without going into too much depth, there's hormone treatments. And the idea behind that is that if you can, so as Nick said, estrogen kind of causes the symptoms and the growth of these endometriosis lesions. So if you can kind of suppress that with different types of hormones, then that should improve the symptoms and potentially also reduce the kind of growth of the disease as well.
Like the burden of the endometriosis in your pelvis, basically. And
then there's also surgery. So there's different types of surgery that you can have depending on you, your wishes, your symptoms, and the endometriosis, where it is and what it's affecting. But it's a lot of people will probably see their GP, and their GP will recommend starting some hormone treatments if they are not trying to get pregnant and they're happy to try and it's safe for them. And often those hormone treatments will actually improve their symptoms completely, or to a level where they're much happier and they're able to go to work and it's not affecting their life as much. And then they may not actually need to go through and have a diagnostic procedure. They may still want to, and that's a discussion that they can have with GP or with any medical professionals. But the purpose of that is really that if what's affecting you is your symptoms, then we can try and treat your symptoms without you having the risks of having a surgical procedure to diagnose endometriosis. And that can work for some people, not for everyone, but that's one option.
Yeah, and as we said before, because we're not entirely sure that endometriosis causes all of the symptoms that people may have come with, if you manage to go on a hormone treatment that helps because it makes your periods lighter, or it makes you not have periods, it helps with your pain, it makes you be able to have intercourse, and your life is kind of better in that sense, then I suppose you have to weigh up whether a diagnostic laparoscopy is necessary, especially in the instance of if the ultrasound scan is normal, so we've not picked up any of this ovarian endometriosis, so these chocolate cysts on your ovaries, if your ultrasound scan is normal and the medication is helping, realistically what we potentially could find is this superficial endometriosis, because we don't really pick that up on a scan. So these are these kind of spots of endometriosis throughout your pelvis, which can be treated with excision, so we remove it surgically, or we can burn it, so like thermal treatment to like remove the lesion. But there is no good evidence that that long-term helps at all symptom-wise. There is a study going on at the moment, which is run out of Edinburgh, and they are looking to see if the treatment of superficial endometriosis actually improves symptoms or not, because we're genuinely just not sure. It's been difficult to recruit to sometimes because if I'm saying, right, you're coming for a diagnostic laparoscopy, I can treat these lesions today, but we're doing a study whereby you would be randomised to either as treating the lesions or not treating the lesions. How do you feel about that?
You can see people being a bit like, I'd like
just
treatment.
What the latter one was best for me.
But it's hard.
It's really difficult because we haven't got the evidence to say that treating the lesions is the better thing to do.
So we need the research to get the evidence.
I think there is that perception though, isn't there, that people want to have the surgery because they think that that will improve the symptoms. Like there's that kind of acceptance without the research.
That's the general kind of understanding is that, well, if there's a surgical treatment available, surely that will
help.
And I think the difficult thing is that it might not, and we don't know for definite yet. And actually, that study would be amazingly useful to be able to counsel women appropriately.
Like, you have an X chance of getting better, X chance of no changes, So I think it would be
excellent.
super when we get the results of that and kind of actually counsel people much better.
Yeah. And again,
I think the problem is, even when people have deep infiltrating endometriosis and it's completely excised, people might feel better for a little bit, but the evidence is not there to say that they are symptom free for a prolonged length of time.
Yeah.
And also, every surgery you will have more adhesions next time, so more things will be stuck to each other. The surgery will be more difficult to get in from the first place. It will potentially require an extra surgeon in the form of a bowel surgeon or a urology surgeon or some kind of different speciality. So yes, surgery definitely has a place for certain people, but it is not a cure. There we go. There's
it's not a cure.
That's
essentially there is no cure for endometriosis, unfortunately, yet. Maybe one day, hopefully.
If we get the funding.
But yeah, there is no cure regardless of whether it's hormone treatments or surgery. Some people get benefit from surgery, some people don't. And I think what's really important is that you've had a discussion with a medical professional, and it's been kind of personalised to you. And you're aware that, it might be helpful, but it might not solve all your problems. But if you choose to go ahead, that's, as long as you're well informed, I think that's the most important thing.
Totally.
And
everyone
is
with
different.
Regards to the hormones, we have discussed this previously, but it's not a one size fits all.
I think this is a common occurring thing here.
It is. Like, there's a theme
it's our
running.
Yeah.
But I think that you can try a couple of different hormonal medications or preparations, because the Mirena coil is something else that you can use to potentially help with endometriosis symptoms or symptoms of chronic pelvic pain. And I think just kind of trying one for a couple of weeks is not, like, you need to give it a little go.
And I think a lot of people maybe don't know that or aren't told that when they start. And so, I think it's really important that you get good counselling when you're initially starting a treatment for something like pelvic pain and heavy periods, that you do need to give it a go if you can for sort of 3 to 6 months. Because a lot of the time the benefit you don't actually notice until 3 months, 6 months. And then if it doesn't work, there are many other options. You can try something else. But I think one thing that's really, really tricky is that we don't have any treatments that are suitable for women who don't want surgery, don't want hormones. And it's really hard then for those women. Like, that's where we need more research and more funding.
We don't have treatments for this, and for the people that want to get pregnant.
People who want to get pregnant,
it's really
it's
difficult
hard.
because you're just like, okay, so all the treatments are contraceptive. So if you want to get pregnant, it's really, I think I really feel for those kind of people, because and they're the ones that potentially aren't going to get pregnant as easily, or will be worried more about not getting pregnant as easily. So it is, that I think is a really difficult situation, and does require kind of counselling and chatting about what could be best, and speaking about, like, optimising painkillers, optimising medications that can decrease the flow of your period when you're on your period. So there are certain things that we can help with. And we've been looking at various different, like, alternative treatment options, and I think there's quite a lot of out there, like there is about everything, cure your cancer by taking this random herbal medication. I think there are certain things with regards to endometriosis as well, and it's really difficult because they're the usuals, in inverted commas, like making sure you're healthy, making sure you're not stressed, making sure that you're thinking about yourself and you're being mindful that you're not doing too much, and that you're looking after yourself, you're exercising. And it's really difficult because if you're in pain, you don't want to exercise.
Or you can't. It's hard.
So I think having these kind of like broad brushes that kind of say you should exercise and eat healthily and then you will be better, like it
doesn't work. It's hard. I mean, so there's a place as well, like, if someone is overweight and they have endometriosis and they want surgery, then it's really important to, if you can, I'm not saying it's easy, but try and lose weight, because that will make the surgery safer. And I think that's a common thing. But also, what we've talked about the physical symptoms, but a massive part of endometriosis is that it will really affect your mental health. And a lot of women will have, depression and anxiety, and sometimes those lifestyle factors can actually help improve those things. Not saying it'll, if you're depressed because you've got endometriosis, go for a run and you'll feel better. But, the general lifestyle advice about doing some exercise if you can, looking after yourself, eating well, can improve your kind of
just
well-being
general
as
well-being.
well. But it is hard.
So I think there's a lot of myths and things
Yeah.
about endometriosis. People know some, but not all. And I think we've touched on quite a few, but one that we've talked about some of the treatments and that surgery doesn't work for everyone. But I think a lot of people do see that a hysterectomy, like getting rid of the womb, will cure endometriosis. And is that true? Is it not?
Yeah, it's a really, really good question. And it's tricky. So, again, it's very person dependent, right? So, as we said, there are different types of endometriosis.
Yeah.
Endometriosis often coexists with other medical conditions, and it's often driven by estrogen. So if you have lots of endometriosis in your pelvis and you just have a hysterectomy, it may not improve your symptoms at all, because you may still, you'll still have your ovaries, you'll still be producing estrogen, and you may still have like endometriosis outside of your uterus.
And potentially complications from a hysterectomy.
which
It's not an
can cause
operation to be
problems.
taken kind of
Lightly,
by any sense, because everything kind of changes. So like people can have urinary problems, they can have bowel problems after a hysterectomy.
And the other thing as well is that like, sorry, go on.
I think it's a really good question, because people assume that if they have their womb removed, then everything will be okay.
I can see that. I feel like people will think, right, the issues are all here. Get rid of it all, the issues will be gone.
Yeah.
But it's not.
No, because it's an estrogen dependent condition. So leaving your ovaries will mean that you still have the condition. The problem is when people are young and they've got endometriosis, like you need that estrogen for so many different things in your life. So your bone health, your cardiovascular health, so your heart health, your risk of dementia. These you need estrogen until menopausal age. So it's that kind of like
it's hard.
weighing it up, what's the best thing to do, because we don't want to remove ovaries because we know that we would just decrease your lifespan. So it's like
I think that's another thing as well with the word hysterectomy. So that literally just means removing your womb. But you can do a hysterectomy and remove your ovaries. And I wonder whether some people think a hysterectomy is removing their ovaries as well, and they want a hysterectomy because that might help, but actually removing your ovaries, as Nick said, at an early age, maybe will improve your endometriosis symptoms, but will shorten your life, will probably mean that you'll have more likely to have a heart attack.
But it puts you into a surgical menopause, which obviously, not obviously, but I've not had a surgical menopause, but speaking to people that have had a surgical menopause, it's like just
change.
One day you've got estrogen, the next day you've got
nothing.
No estrogen, and it's like a massive change in your life. So you are full blown in the menopause straight away. There is no perimenopause easing into menopause, so you have all the symptoms of menopause straight away. So then you're like, well, you have to decide about kind of a HRT situation, but if you've got endometriosis, you would want to have progesterone part of your HRT. We discussed this in one of our later episodes, or we're planning to with our HRT. So it's a really catch situation.
Yeah. It might not, but I think it's not a simple answer. And I think you really have to have a discussion with your consultant or gynecological person, and ask them about your specific risks. And you really do need to have an in-depth discussion about that. And I think one really important thing is that you won't be guaranteed that will improve your pain. And that's a really big thing, because it's a big thing to go through, especially with all of the risks.
If you just have your womb removed and it hasn't decreased your pain, and then you've come back for your ovaries removed, say like 5 years later, that operation is going to be harder compared as well. So, because I said every operation we do makes it more difficult. When you've just left ovaries, they like get very buried in.
Yeah, they shrink down, don't they? Disappear. There is, we talked kind of broadly about hormone treatments, but there is also a kind of hormonal injection that some people will be offered, which is called GnRH agonist or antagonist. And essentially what it does is it kind of shuts down your hormone production. So it's a temporary menopause.
Is this the chemical menopause?
Yeah.
Because I've heard a lot about that lately. I
Yeah.
think it's sort of like had a little spike on social media of
Yeah.
people saying,
Okay.
So it's
I'm
a kind
25
of-
and been offered it. And it's like, wait, what?
It's an option. So because it's temporary, it's a good option. And some people use it as a... So if you've tried certain hormone treatments and they've not worked and you're considering surgery, something like a hysterectomy, if your symptoms improve with this treatment, then that might tell you that maybe your symptoms will improve if you have your ovaries and your uterus removed.
Okay, yeah.
Again, it's very person specific and age and other factors would come into it. But that's one temporary option you can try.
We also do use it. So if you have a surgery and you've got superficial endometriosis and we've removed the superficial endometriosis, what we would often do is put you on Prostat, which is one of the injectables. I'm just thinking lots of people use different ones, but that's one of the ones that we use to kind of dampen everything down.
Okay.
So if we've removed what's there, we're going to dampen everything down. We've popped a Mirena coil in as well. So the Mirena needs, or the progesterone coil needs a little bit of time to bed in, thin out that line of the womb. Then we've decreased everything by giving you this injection as well. So it's to kind of try and dampen everything, and then hopefully when your hormones kind of kick back in again, you've got the Mirena working, or you've got the progesterone only pill working, or whatever you have chosen on the back of having this kind of chemical.
So it kind of gives the treatment like the best chance of working for you?
Yeah, so we use it like that, but I think it's very important to know, and on what we said before about you can't just go around removing people's ovaries because you're going to like slip into all sorts of different problems. So if you're going to give people a chemical menopause with one of these injectables, you need to think about giving HRT.
Oh, okay.
So you can't leave people on it long term because you are literally just going to be losing bone health and increasing all these risks of lots of different conditions.
Yeah.
So if you're going to be on it slightly longer, then you would need add back HRT as well.
So that helps to kind of, because obviously the chemical menopause will give you symptoms of menopause, and it's really important that you know that and you've had counselling about that if you want to try it. But then the add back HRT can reduce those symptoms. Doesn't mean that they will not
Completely
happen. A lot of
go.
people do have symptoms of menopause and it's rubbish. But the HRT can kind of help to reduce them a little bit. And again, it's not something that you would have forever because again, you are putting yourself at those risks of menopause earlier on in your life.
You're definitely not allowed it forever.
It's usually like 6 months or 2 years up to.
People have it for short amounts of time. So usually you would trial it for 6 months. Some people have it up to a year, but people are very reluctant to prescribe it again after that because
of those
makes sense,
the risks for everything else are just going up.
Another myth about the cure is that pregnancy can cure endometriosis. What are our thoughts on that?
So this is something that used to be really widely shared by medical professionals, and I think the theory behind it is that, okay, you're pregnant, so you've got more progesterone, and progesterone is useful to help treat symptoms of endometriosis, but so it's kind of true in some ways, but it's also just not helpful because I think
a lot of people, if people are struggling to get pregnant,
I
they're
don't
thinking
think it's helpful.
the only cure is if I get pregnant, and I can't get pregnant, which means I'm doomed.
So much pressure on it there.
I think
there's a lot of pressure on
it's
it.
that whole it's not a cure, but when you are pregnant you may feel better. So when you are pregnant you're not going to be having periods, so that's not going to be an issue. When you are pregnant, your endometriosis shouldn't be kind of being fed like it is when you're not pregnant. So that you should have respite from endometriosis when you're pregnant. So it's like respite rather than a cure.
But in some people they're pregnant and they still have pain. It doesn't mean that it will definitely make your symptoms
Or you
better.
might have pain from something else when you're pregnant.
It's not an easy thing to go through.
All of the different things when you're pregnant. So
We also got lots of questions on social media about endometriosis. So should we touch on some of those?
Yep.
Yeah. So I guess the first one that's actually really interesting here is who can get it? Sort of, can it affect anyone? And also, is there like a genetic link? If your mum's got it, are you likely to have it? If you have a daughter, that kind of thing.
Yeah, it's a really good question. So yes, anyone can get it. again, as we said before, there's the theory that retrograde menstruation happens in everyone, but a certain number of people will develop endometriosis potentially for a different reason. But there is a genetic link. So there's been lots of kind of like huge genetic studies looking at this specifically, and you are more likely to get endometriosis or have it if your mum or your sister has had it in the past as well. So there is something potentially there in the genes that kind of is passed on that makes you more predisposed to getting it. It doesn't mean you will. So if your mum has it, you won't definitely get it.
It's not guaranteed.
No, but evidence does suggest there's a little bit of a link there.
Someone did ask as well if you can be born with it.
Ooh, so there is a lot of things about paediatric endometriosis. Let me just quickly, so the problem with genetics and endometriosis is going back to what we discussed earlier about to diagnose endometriosis, you need a diagnostic laparoscopy. So there's lots of studies that have looked into genetics of endometriosis, but a lot of them are flawed because although you all may say that you've not got endometriosis because you've not got symptoms of endometriosis or that kind of thing. We don't know because none of you had a diagnostic lab.
But you can't just give everyone a diagnostic lab
we've
to
put
figure out.
kind of like, and I know this doesn't count, but we've put you three into the control group, no endometriosis, and then we've put these 6 into endometriosis because they've all had a diagnostic lab that says endometriosis.
But we might also have it.
Like 1 of you, 2 of you, 3, you might all have endometriosis. So that data is just completely skewed.
So flawed, It's hard.
So
it's such a complex disease.
It's really very difficult. And lots of people have looked at it in lots of different ways, and they think by getting lots and lots of data, then you could kind of weed out the fact that you're going to have some people in your control that would have endometriosis, but it's still not going to be perfect, is it at all? It's just not that simple to work out. There is, I'm sure, a genetic link, but it's just working out what genes are involved.
Not
that straightforward.
No. But I think it's really important to know that like it doesn't mean you will get it if someone in your family has it. You might get it, but it doesn't mean you definitely will.
The paediatric, babies, children having endometriosis when they're born, there is research with regards to this. It's quite old research, and it's looking at children that have unfortunately passed away, babies that have passed away, and saying that they do have deposits of endometrium in their pelvis. It's kind of a whole different ball game in a sense of like looking
potentially
into
a
this.
different, same disease in terms of like it looks like endometriosis, but maybe a completely different cause.
Because realistically they've not started their periods, so they've not had this retrograde menstruation. But we know that some people that haven't started periods will be having retrograde menstruation because they've got some anomaly, which means that they're not passing blood through the vagina. So you could have an imperforate hymen, so you're actually not bleeding out through your vagina, it's just kind of all sitting there and getting pushed back up. Or you could have a cervix that's not attached to your womb, or a cervix that's not got an opening into your vagina, or an absent
and I suppose you wouldn't find out about these things until something.
So people that have got these kind of different situations anatomy wise will be more prone to having endometriosis, and that's why it sticks with the whole retrograde menstruation, like you're bleeding through your tubes because you can't bleed anywhere else. But there is research with regards to paediatrics, so children, babies, endometriosis, and some people are kind of like maybe everybody who has it from when they're when they have it when they're born. So they were trying to do research looking at, because often with the withdrawal of hormones from your mum, a lot of babies will have like a period, so have a little bleed when they're a baby. So are those people more susceptible to endometriosis later in life? So there has been all different research into this, so great question. But there isn't a definitive answer. So did you have a bleed when you were a baby? Do you go on to have endometriosis? We don't know the right answer to that. And I think there'll be more and more research done into it. I think a lot of people don't realise that's the thing that happens to babies until it happens to their baby or a baby that they know. And then they're like, oh, it's a thing. Oh, right, okay. And then it's that whole, you have such a massive drop of estrogen and you're kind of like postmenopausal for a short time after you've had your baby, and nobody tells you that you're going to have like night sweats and vaginal dryness and all this kind of stuff, and people don't know unless they discuss it and that it's open, and I think that will come out with regards to this like neonatal, like babies having a bleed, and does it relate to endometriosis later on.
I guess that just touched on menopause there. People are asking if their endometriosis symptoms will sort of stop, decrease, get better, get worse as they go through the menopause with those changes in the hormones.
Really good question, and also not an easy one.
What shock.
So some people, some people, as we said, estrogen kind of drives the symptoms of endometriosis. So, in theory then, if you're not producing estrogen, then your symptoms should go away. So if you are postmenopausal, then your symptoms should go away. And in some women that happens. In other women it doesn't, and also there's is it definitely caused by endometriosis, or could it be that you've had endometriosis in the past and now you've got lots of scar tissue, and even though the endometriosis isn't active, the scar tissue is still causing your pain. And then there's also the kind of like element of, so if I want to start HRT, am I going to then cause my endometriosis symptoms to flare up again? And we do touch on this in an upcoming episode on HRT, but in those women it would be a discussion about having some progesterone as well as estrogen to try and prevent that happening. So in theory it sounds great, doesn't it? Like you go through menopause and all your period problems end, but unfortunately not for everyone.
It's not always that simple.
It's not the case, and I think, as Alison said, it's complicated. Most people will be better after menopause. Not all people will be better after menopause.
And another question is, can it become cancer, or does it often become cancer?
So it's not a cancerous condition. So although it's sort of, it can grow and invade other tissues, it's still normal cells. They don't become abnormal cancerous cells. So yes, it's what we call like a benign or a non-malignant gynecological condition.
And someone that has asked, will it get better without treatment?
Really good question.
So as we discussed before, we don't know the life cycle of endometriosis, and I think when people say, oh well, it progresses from 1 to 4, you need to get it early, that doesn't happen to everybody, and I fundamentally we can say that doesn't happen to everybody, and we don't know the progression cycle, or if that even happens, or if you have peritoneal, so just on the peritoneum endometriosis, does it ever change to anything else? Possibly not. So I don't think people should be worried that if they don't have treatment, they're going to end up with awful endometriosis. I think that we need to be treating the symptoms. So if you're telling me that the heavy painful periods are the worst bit of it, then we need to be treating heavy painful periods. If you're telling me that it's the fatigue and the bloating that's the biggest problem, then we need to be thinking about how we can change things to try and kind of optimize how you're living, so that we can kind of make your quality of life as good as it can be. And I think it's this like targeting what the main problem is, and drilling down to like, why are we seeing you? What's the problem? How can we make that problem better?
I think that is all for the questions.
Right.
But overall, I feel that it is just different for everyone, isn't it?
Yeah.
As with a lot of the things that we've discussed.
That's why it's so hard as well, isn't it? I think in an ideal situation, if someone has endometriosis, they would get referred to a clinic where you've got an endometriosis specialist, but you've also got someone who's there to support your psychological well-being.
A physio.
You've also got a physiotherapist.
There's loads of stuff with physio and nutritionist. Being able to help symptoms of endometriosis. So there's really good evidence with regards to that. And people are like, well, I've got endometriosis, I don't need to see a physio, but they're specialist physios that help. And if the funding was there for these services, and some clinics are set up better than others. We've got an endometriosis centre, we're very lucky to have that. But you need to have an on-hand physiotherapist, psychologist, nutritionist, surgeon, but not just a surgeon, but like a bowel surgeon, a urology surgeon that have got special interest in endometriosis. And fertility is, you have to have that as well. We do fertility preservation for some people with certain forms of endometriosis. If they have endometriosis that is literally destructive for their ovaries, and you are worried that they would not be able to kind of get to the age where they want to be able to get pregnant with ovaries still intact, then there are certain times that we can put in individual funding requests for people to have fertility preservation. So working as a team for these people affected is kind of, it's the only way that you're going to get kind of good service.
Not everyone would need to see each of those people, but it would be amazing if you could have enough money to have all of those specialists together to give real like holistic care to someone with
more
endometriosis.
Discussions throughout, so before I think discussing what your options are, what the risks, everything, and then discussions after as well.
I think if you had this kind of service though, you know, with everybody there, then people potentially would need to be seen less often because they would have more answers. And more
because there's lots of questions.
More answers and more kind of day-to-day coping mechanisms with regards to like how can we make this better, how can we ensure that you can go to work, how can we ensure that you can exercise, what medications could be used, what like different exercises could be used that would make this better. So I think instead of that whole like being on a treadmill of just coming back to clinic and feeling like nothing's happening, if we could have a more like holistic care package, then it would be great. It would really be good.
One day.
Dream.
With more funding. But yeah, I think that, you know, that's one of the reasons we wanted to do this episode, really, because the way that healthcare is set up often, there's not a lot of time, and really it is really good for you to have as much knowledge as you can going into it, so that you can get the most out of the limited time you actually get in consultations as well.
So you can advocate.
Just advocating for yourself. Very important.
Well, thank you.
Lovely. So, thank you for listening to this episode all about the Endometriosis Essentials. Please tune in for our next episode, which is on the HRT lowdown, where we'll be discussing hormone replacement therapy, what you need to know if you are someone that's decided to have it and it's safe for you to have it. Please go on.
If you liked this episode, make sure to give us a review, and you can have a look on Instagram as well, where we'll put little snippets out of future episodes.
So that's Between Two Ovaries on Instagram. And anywhere else? Are we also on X?
TikTok?
Everywhere. Thanks for listening.
Thank you.
So, quick disclaimer, all opinions and views expressed in the podcast are our own and are not affiliated with where we work. And information given shouldn't be taken as medical advice.
And you can follow us on Instagram at Between Two Ovaries.
And please follow us on wherever you are listening to our podcast.
Thank you.